Hello, my name is Dr. Sanjeev Bagga, and I'm going to be talking about chronic inflammatory demyelinating polyneuropathy or CIDP. This is a presentation for lay people. My references and acknowledgements include American Journal of Neuroradiology, Merck Manual, and this is only for patient education and not for offering medical advice. What is demyelination? Myelin sheaths are coverings of nerve fibers and they accelerate transmission of nerve impulses. In disorders that affect myelin, there is interruption of nerve transmission. As a result, it causes problems. Now, what is polyneuropathy? Polyneuropathy means that the nerves are diffusely involved and the involvement is not confined to a single nerve or a single limb, and this is typically bilaterally symmetrical. That means it affects both the upper arms and lower arms. Now, before I go to the CIDP, I would like to tell you a little bit about Guillain-Barré syndrome or GBS, which is an acute, rapidly progressive but self-limited polyneuropathy. There is muscle weakness and mild distal sensory loss. By distal, I mean it involves the feet or the more distal or the peripheral part of the limbs. Now, the cause is autoimmune. For the layperson, autoimmune disease means a condition in which the person's own immune system mistakenly starts attacking one's own body. And what are immunoglobulins? These are proteins molecules which are produced by white blood cells, and just like we have a lock and for it is we have a specific key, so the antibodies recognize and bind to particular antigens, which you can think of as locks, and these could be bacteria or viruses, and help destroy them. Now, chronic inflammatory demyelinating polyneuropathy is a immune mediated polyneuropathy, and it typically causes symmetric weakness of the proximal and distal muscles. Proximal means towards the more upper part, whereas distal could be considered more towards the periphery or the lower part of the muscles. So if you're talking about the upper limbs or the arms, the muscles of the hands would be more involved. If it is distal, and proximal is towards the shoulder. Similarly, in case of legs, it would be proximal would mean towards the hip and distal would mean towards the feet. Now, in this particular disease entity, the progression continues for more than 2 months, and the symptoms are like Guillain-Barré. That means there is muscle weakness, but unlike Guillain-Barré, which is monophasic and self-limited, this disease is a progressive disease. um, it starts slowly and it becomes worse slowly. It goes and comes back, so it relapses, and there are times of recovery. The recovery may be partial or complete, and there is weakness of the limbs, which is the main symptom, and it is more prominent than the sensory abnormalities. In most patients, the autonomic function is affected much less than in case of Guillain-Barré syndrome. Now, autonomic function includes processes such as heart rate, digestion, respiratory rate, urination, etc. Now, how do we diagnose or make a diagnosis? Um, the doctors would do a CSF analysis, which is drawing some fluid, which typically circulates around the spinal cord and the brain. And then there are tests called the Electro diagnostic tests, which are of two parts. One is called the nerve conduction study, where you place sensors over the nerves in the arms and legs and then stimulate these nerves with small electric sensations. And the doctor is able to see whether the nerves are functioning normally or not. And the second part is the electromyography, which is placing small needles in the muscles of the arms and legs. And this is to evaluate if the muscles are working fine and if the muscles are receiving proper signal from the nerves. What is the treatment for this particular disease? There are we can treat these patients with immunoglobulins intravenously. We can give these patients steroids, and then we can do what is called plasma exchange. And typically, the immunoglobulin treatment is more expensive, but is often offered first because it causes less side effects compared to long-term steroid use, and it is easy to administer compared to plasma exchange. Now, there are new studies which suggest that if you give pulse corticosteroids, it can result in longer remissions and a lower rate of serious side effects compared to immunoglobulins. Some patients may respond better with a combination of immunoglobulins and steroids. As far as the plasma exchange is concerned, it does not have any long-term adverse effects like steroids. But the problem with the plasma exchange is that you need to put an indwelling catheter or port, and so that becomes an invasive procedure, and then you have to deal with large fluid shifts, which may lead to lowering of blood pressure. Now, people who do not respond to IV immunoglobulins can be given plasma exchange, and we can give immunoglobulins by IV route or subcutaneously. And certainly, the other treatment that we can offer is what are called immunosuppressants, which may be helpful and can reduce the dependence on steroids. Important to note that the treatment may be needed for a long time. Now, what is therapeutic plasma exchange? You can think of this as a way to clean your blood, and it works somewhat like kidney dialysis. During the treatment, the plasma or the liquid part of the blood is replaced with plasma from a donor or with a plasma substitute. Now, I'm showing you MRI images. These are images of the neck or the cervical spine, so to say. And then the second image on the right is of the lumbar spine or the lower part of your back. And as you can see, these structures, the white structures, these are thickened onion-like nerves, symmetrically thickened and enlarged. And this is an MRI of the brain, which shows these white spots around the ventricles, which again are suggestive of abnormality.